simple, and if anyone has any questions, please feel free to ask in the middle or at the end of the presentation, however you feel like. I'll be talking about mediastinal masses today, from pulmonary standpoint, how we come across with diagnosing um, and treating these mediastinal masses and how they're important for patients with acute and chronic lung conditions and otherwise systemic conditions as well. Moving on to the second slide. Um, this is just a comparison. Like, there are two methods to compare what side of mediastinal compartments are there. One is the conventional method, where everything front of the heart is anterior, everything back of the heart is posterior, and in the middle is the heart, is the middle compartment. But there's a radiological method as well, which again divides it into anterior, middle, and posterior. But the division here is the anterior line. For the anterior line, it's basically the line which extends from trachea to the posterior border of the heart. Anything in front of it is anterior. And then there is one line which is 1 centimeter behind the anterior line. That's anything behind that is posterior. That's basically running along the anterior border of the thoracic vertebrae. And everything in the middle is basically the middle compartment. Most of our diseases which are classified in anterior, middle, and posterior are based on the conventional method. Sometimes the radiological method is important in terms of intervention and other stuff, but most of the times we go with the conventional method. Moving on to the other slide. There are some normal mediastinum structures which are present in anterior, middle, and posterior, of course. So we should know them before we know the abnormal pathology. The anteriors are basically the T's, the thymus gland, the thyroid, the parathyroid, the lymphatic tissue, lymph nodes, and the connective tissue. And then middle has, of course, all the important structures like heart, pericardium, aortic arch, great vessels, the pulmonary artery, trachea, some lymph nodes, and then connective tissue and phrenic in the upper vagus nerve. The posterior compartment has the esophagus, the descending aorta, the azygos and hemiazygos vein, thoracic duct, the lower portions of the vagus nerve, and then some sympathetic chain and connective tissue. From pulmonary standpoint, going to the other slide, from the pulmonary standpoint, we very often come across with something called mediastinal lymph nodes, which can be elevated in conditions like infections, cancers, and some chronic lung conditions like sarcoidosis, some interstitial lung disease, black lung also can give you sometimes mediastinal lymphadenopathy. So it's important to realize the anatomy, and then we have come across numbering those lymph nodes, which is important for lung cancer because that determines the staging of the lung cancer. And there's an easy way to know about that. Like, when you do the staging of the lung cancer with the nodal involvement, it becomes N1, N2, and N3. So let's assume that the tumor is in the right side. So N1 would be ipsilateral lymph nodes, double digit. So a 10 on the right side would be stage N1. As soon as you go to single digit, which is 4 or 7 or 8 or 2, it becomes disease N2. And then when you go to double digit on the other side, that's contralateral, that means 10L or 11L, it becomes N3. So it's important to know the anatomy of these lymph nodes, and then when you're biopsying them, because based on whether they are positive or negative, it affects the staging of the lung cancer, and then it affects the treatment, of course. Moving to the next slide, this is just the CAT scan imaging of lymph nodes as to how they are seen on the CAT scan. The first one is basically a 2, the second one is like a 4. B is 2R, and then C is again 4. D is 4, and then you go down, and after the carina, it's like 7. So anatomically, In terms of the CAT scan, you can see that on the right side, anything above the azygos is a 4, and anything below the azygos is a 10. On the left side, in between the aorta and the pulmonary artery is a 4L. After the pulmonary artery is 10L. And then in terms of bronchoscopically seeing, you know that on the carina is your 7. And then after the right upper lobe takeoff, underneath is your 11RS. And then below the right mid lobe takeoff is your 11RI. So 11R station is divided into superior and inferior. Um, Moving on to the other slide, what are the disorders which present as masses in the mediastinum? The biggest that we encounter here is lung cancer and infection sometimes. And then, as I said, the interstitial lung disease is like sarcoidosis most often. Sometimes silicosis, berylliosis can also give you mediastinal lymphadenopathy. But just if you base it on the compartments and what are the things that can give you masses there, talking about those, the anterior mediastinum, most common are thymic neoplasms, and then the germ cell tumors like the teratomas and the seminomas, they're very common there. Now, talking about lymphomas, Hodgkin's and non-Hodgkin's always come up with lymphadenopathy, and most of the times you found it just in the anterior mediastinum. And as I was telling earlier, thyroid and parathyroid are in the anterior compartment, so their cancers would come as anterior mediastinal masses. Um, Most of the mesenchymal tumors like lipoma, fibroma, lymphangioma, hemangioma can also present as anterior mediastinal masses. The Morgagni type of diaphragmatic hernia would be an anterior mediastinal mass. It's different because it's important because the Bogdalic type of the diaphragmatic hernia is in the posterior mediastinal part. So if you see a hernia, which is in the anterior, it's mostly Morgagni. In the middle mediastinum, we typically see lymphadenopathies, which I was telling you could be from a granulomatous inflammation, could be from cancer, or could be just angiofollicular lymphoid hyperplasia, which is the Castleman disease. You can also see developmental cysts in the middle mediastinum. These are like the cardial cysts, pericardial cysts. You can also see bronchogenic and enteric cysts. A hiatal diaphragmatic hernia can also be seen in the middle mediastinum. Posterior mediastinum typically has neurogenic tumors. You can see a meningocele there. You can see some esophageal lesions like carcinoma and diverticulums, and the diaphragmatic hernia, the Bogdalic type that I was just saying, and then miscellaneous. Moving to the next slide. I'm sorry I have to say that every time because I'm not moving it. Um, the systemic syndromes which could be associated with mediastinal masses. So you can have endocrine effects coming from the thyroid and parathyroid tumors. So you can see hypercalcemia typically in a parathyroid adenoma. You can see hypertension if patient has pheochromocytoma, which is infiltrated in the mediastinum. You can see symptoms of Cushing syndrome if the patient has a carcinoid tumor or a thymoma. Hypoglycemia typically in mesenchymal tumors, gynecomastia and germ cell tumors, and diarrhea that you see in ganglioneuromas and neuroblastomas. You can see some autoimmune effects. Typically, they happen in thymomas, where you see a bunch of symptoms like myasthenia gravis, red cell aplasias, myocarditis, hypogammaglobulinemia. Also in neuroblastoma, you can see opsomyoclonus. So these are the autoimmune effects. In terms of congenital syndromes, if you have, you can have neurofibromatosis, multiple endocrine neoplasias, and then some unknown causes like Hodgkin's lymphoma can give you alcohol-induced pain and the fever and the night sweats that happens with lymphomas. Moving to the next one, there are some characteristic radiographic appearances, features of some of the mediastinal masses that may or may not be helpful. Sometimes they lead us towards a diagnosis, sometimes they lead us away from the diagnosis. So it's important to correlate them clinically as well. But if you're seeing a very bulky mass on an initial presentation in the anterior, it depending upon the age, it could be lymphoma, germ cell, or thymoma. a teardrop-shaped mass within the interlobal fissure, very characteristic of a bronchogenic cyst. And if it's near the heart, could be a pericardial cyst. And then if you see fat density on the CAT scan, like if there's a lesion and you put Hounsfield number on it, and it correlates with the fat density, then it's most likely a mediastinal lipomatosis. If you see calcification in the mass, again, if it's in the rim of the mass, it could be silicosis. We all know it could be from the eggshell calcification, which is very common in silicosis. And then in the center of mass, it could be from thyroid adenoma and teratoma. Now, if you see teeth or bone, could be a teratoma. You can see phlebots in the hemangioma part of it. If you see the air fluid level in the mass, it could be hernias, it could be abscesses, it could be cystic teratomas as well. If you see mass with an associated parenchymal opacity, so you see a mediastinal mass, and there's also a parenchymal opacity, that is the lung opacity, then that points towards either lung cancer or granulomatous inflammation, interstitial lung disease sort of picture. Um, and then you can see a mass with associated pleural effusion, like if you have a mediastinal mass and you also have pleural effusion. That points again more towards metastasis, but some of the granulomatous inflammation can also give you that. You can see superior vena cava obstruction sometimes if it's like massive obstruction in the mediastinum. Typically, a bronchogenic carcinoma, a lymphoma can cause this. Sometimes a catheter-associated thrombosis can also give you an SVC obstruction syndrome. Long-standing cases when the patient has mediastinal fibrosis, that can give you superior vena cava obstruction symptoms. For the erosion and destruction of bone, you can see it in arterial aneurysms, the tumors of the peripheral nerves or sympathetic ganglia, and then the meningocytes. Spine or rib deformities can be seen in enteric cysts. So these are some of the characteristic CAT scan changes, radiographic appearances that we can see on mediastinal masses. This is a picture to show you some common examples, like the mediastinal lipomatosis, how it looks on the CAT scan. You can see the infiltration around the heart, which is like the Hounsfield unit is pretty much similar to the subacute fat tissue. So that's lipomatosis. You can see the sarcoidosis eggshell calcification, the second picture on the top right. And then bottom left, you can see the mediastinal teratoma. It was a huge mass, which was like resected and came out to be this. And then the typical teardrop appearance that I was telling you, if you're seeing it in a fissure or near to the heart, this one is a pericardial cyst. But if you're seeing it away from the heart and it's right in the fissure, it could be a bronchogenic cyst as well. Typically, they are asymptomatic and found incidentally, just needs to be washed. Going to the next slide, just relative frequencies. If you encounter a mediastinal mass in adult children, how often do you think what it should be? So the most common ones in adults are thymomas, developmental cysts, and the neurogenic tumors. These are the three that should always be in your differential when you're seeing an adult patient with this. That being said, you also have high incidences of lymphoma and germ cell tumors. And then the rare ones are the endocrine masses, the mesenchymal tumors, and other malignancies. Although the endocrine ones are the rare ones, they are the ones which are more vocal, like you'll get more symptoms in a thyroid, parathyroid carcinoid. Now, in children, it's about the same, but the only difference is in the thymoma. So you don't see thymoma in children, but then that is taken over by lymphoma. So the percentage of lymphoma in children is more than that in adults. And the neurogenic tumors. So it's said that almost every time you see a patient with a mediastinal mass, it's probably a neurogenic tumor. But then the developmental cyst, as I said, and the lymphomas are also pretty common. So they should be also looked into. Moving to the other one, talking about just briefly talking about some of the things that we come across more, which are more common, and how we can deal with them, how to diagnose, and what are the treatment. So talking about thymoma, it's the most common neoplasm arising in the anterior mediastinum in adults. Incidence about 0.13. Typical age incidence is 40 to 60, Asian, African American. which has an equal gender predilection. The advanced disease involves extension into local structures and transtriformatic extension into the abdomen and pericardial involvement. So watch for that. The lymphogenous and the hematogenous metastases are rare. So the advancement is only locally, and less likely would it be from lymphatic and blood. The classification is based on histological features. It does not accurately predict the clinical outcome. It is more for the diagnosis point of view. The treatment is based on basically presence and degree of tumor invasion. The Masoka stage is helpful. It helps you in the treatment. It is based on the degree of invasion of the tumor through the capsule into the adjacent structures. Basically, it's divided into 1, 2, 3, 4. Part 2 is divided into A and B, and 4 is divided into A and B again. So 1 is when the tumor is well encapsulated. 2 is when there is capsular invasion. Now, is it microscopic or macroscopic? So when it's microscopic, it's A. When it's macroscopic into the fatty tissue, it becomes B. Now the invasion has already happened. The capsule has already been invaded. Now further invasion into blood vessels, pericardium, or lung is stage 3. So that involves majority of the cases that have spread. Now, if it spreads to pleura or pericardial dissemination, it's 4A. And then when there is lymphatic or hematogenous metastasis, it's stage 4B. So that's pretty much the clinical staging for the thymomas and guides us in the treatment as well. The Moran and colleagues, they recently proposed a new staging system which helps us in the overall prognosis and recurrence is based on the extent of tumor infiltration, but the Masoka is the one which is more commonly used. Um, Moving on, clinically, 1/3 of the patients will present with non-specific chest pain, cough, dyspnea due to the local tumor effects that we have. 40 to 70% may have about the parathymic syndromes that have been recognized. And then thymomas are associated with basically numerous systemic syndromes. Most of them are autoimmune in nature. You can see myasthenia gravis, pure red blood cell aplasia, myocarditis, and hypogammaglobulinemia. There's also an increased incidence of collagen vascular disease, Whipple disease, and malignancy elsewhere. In terms of imaging, they would appear as ovoid, smooth lobulated unilateral mass near the junction of the heart and great vessels. Thymoma usually distorts the gland's normal shape and extends to one side. Thymic hyperplasia appears typically symmetrical on the contrary. So it's important to make a differentiation. And if it's just based on the appearance, then thymic hyperplasia is very symmetrical, whereas thymoma is like distorted. On a CAT scan, it's like solid 5 to 10 centimeter anterior medial mass, which is outlined by fat most of the times. About 1/3 can also have like cystic, necrotic, or hemorrhagic areas, which can typically be seen by with the help of Hounsfield units. If you do the contrast enhanced CAT scan, then it's helpful in staging because it'll tell you about the vascular involvement. And then the MRI can distinguish between a cystic thymoma or a thymic carcinoma. Most thymomas have low FDG uptake, so therefore PETs are not very helpful. When you have this appearance and you've made up your mind that it's probably a thymoma based on the appearance, the age, and the symptoms, then it would need a diagnostic workup in terms of an invasive procedure that I was just going to talk about. The mainstay of the treatment is surgical resection, but diagnosing them, can you move on to the next slide? Sorry. The mainstay of the therapy is basically surgical resection. You can have adjunctive treatment with postoperative radiotherapy sometimes. Preoperative or adjunct chemo, like we used in other carcinomas, is only for more advanced stages here. It recurs in nearly 1/3 of the patients, so needs to keep an eye with repeated imagings. Higher Masoka stagings, incomplete resection, and non-thymoma histology were factors in recurrence and worsening survival. So 3 things that are important to look for. Although the surgical dissection is the mainstay of treatment, diagnosing them with a bronchoscopy, guided, EBUS guided mediastinal biopsies versus mediastinoscopy and mediastinal excision, mediastinal nodal excision, can both be done. Most of the times we do the diagnosis first and then think about the treatment in terms of excision. This was just a 57-year-old previously healthy man with chest radiograph after a motor vehicle accident. It demonstrated the mass that you can see in the front, but this was abutting and inseparable from the heart, confirmed to be in the anterior mediastinum. The CT revealed the 12 centimeter mass, which is labeled as the T there. The biopsy confirmed this to be a thymoma. You can see the epithelial cells with pale staining, nuclei, and then many small lymphocytes. And then on the bottom right, you can see that the epithelial cells are highlighted by the pancytokeratin stain, which is used for thymoma. Moving on, thymic carcinoma, they're basically aggressive epithelial malignancy which invades locally and metastasizes. It's predominantly in middle-aged men. Presence with cough, dyspnea, chest pain, or non-specific systemic symptoms. As I was telling you earlier, thymic carcinomas are heterogeneous masses with areas of necrosis and calcifications. They're highly FDG avid on PET scan. So PET scans are very helpful for thymic carcinomas. Again, the treatment of choice is surgical dissection, and then after that, they would need chemo and radiotherapy most of the times. And if it's unresectable, then just chemo and radiotherapy. Thymic carcinoma is one of the poor prognostic tumors. You can see in this picture the FDG PET avid of this thymic carcinoma. This was the patient who had like Cushing syndrome because of this mass, thymic carcinoma. There's something called a thymic, if you move to the next picture, there's something called the thymic rebound hyperplasia. You can compare these images where image A is an enhanced chest CT in a young patient with breast malignancy at time of diagnosis, shows minimal soft tissue mixed with fat right there where the arrows are pointed. This is consistent with the normal residual thymus. And then in image B, you can see that it shows marked increase in the soft tissue within the anterior mediastinum several months following chemotherapy. This is called thymic rebound. The appearance can be difficult to distinguish from neoplasia, but it should not be treated as a carcinoma immediately. And then you can see 1 year, the CAT scan 1 year after shows the return to a normal appearance of the thymus. So chemotherapy, rarely radiation therapy also can give you something called the thymic rebound hyperplasia, which just needs to be washed unless it's giving you compressive symptoms. Moving on, just X-ray. If anyone has any thoughts on it, questions for the audience, basically. What do you think is going on? Cut to the chase. This is the lateral one.
Yeah, there's no heart present. I'm sorry, I was triple mute myself. There's no heart present in that X-ray, or at least not. If it is, it's well hidden and aligned in some weird direction.
Yeah, if you move, yeah, you're right. There's no heart in that X-ray. If you move to the other picture, can you move to the other slide? So there's no heart there, basically. And then if you move to the other slide after this. So this was, I think, the first publication which was given, which showed that there is no heart. Basically, the heart is in the stomach. And there's a name to this condition, which was, when it was published, it was published at that name. You can see that it's like in the peritoneal cavity, but this I sometimes just do to try and create some humor for the audience. If you move to the next slide, This was basically an April Fool case published in radiopedia.org, and this is an imaginary picture. Um, they called it a controversial monograph, which is an unusual case of ectopia cardia epigasticum. This was back in India, but it is just a fiction. This is imaginary. If you see that there's an error. You'll always see it hard in the chest X-ray. Moving to the next slide, where I was going to talk about the developmental cyst. It compromises 10 to 20% of all the mediastinal masses. You can see the bronchogenic, enteric, or the pericardial cysts. The bronchogenic cysts typically are in the respiratory lining, and the enteric cysts are along the GI lining. Moving to the next one, as I was saying, bronchogenic cysts are generally found near the large airways just posterior to the carina. The cyst wall often contains cartilage and respiratory epithelium. They're discovered incidentally and cause no symptoms. You can have complications, infection, airway obstruction, pulmonary artery compression, hemodynamic collapse, and rupture. That's when they need intervention most often. These are just types of bronchogenic cysts. This is the one that was like followed for 7 years. You can see that presentation. It was big enough. 2 years prior to presentation, it was smaller. And then just the different sections. How it has grown over a period of 7 years. Typically, when it grows to this size, it starts to have pressure symptoms, and that's when it needs resection. But most of the people are comfortable just watching it if it's not growing a lot in the size. This is just pathological picture of the bronchogenic cyst. You can see on the CAT scan as well that a part shows like very mildly hyperattenuating structure in the subcarinal space. And then you compare it with the MRI, you see the unenhanced double inversion recovery image. On the image C, you see the same lesion in the DIR image. Note that there is very high signal on the fluid sensitive DIR image, which is consistent with the fluid, and that's when it tells you that it's a bronchogenic cyst. You can see that there is normal bronchus on the lesion, including the presence of cartilage plates and submucosal glands. In this particular case, the parenchyma showed that there were secondary changes due to airway obstructions, but typically, if it's not obstructing, if it's not giving you any pressure symptoms, then you just need to watch it. Moving on to other developmental cysts, which is the enteric cyst. They're similar in location and appearance, but they have digestive tract epithelium on pathology, and their most common cysts found in infants and children. It may be associated with spinal extension and malformations of the vertebral column called neuroenteric cysts. Maybe multiple and associated with duplications of the portions of GI tract. Moving on to pericardial cysts, they're 1/3 of the cystic masses in adults. They lie against the pericardium, typically diaphragm or anterior chest wall in the right cardiophrenic angle. May or may not communicate with the pericardial space, but when it becomes communicating, that's when the treatment gets a little tricky. They're mostly harmless, but they can have complications like right ventricular outflow tract obstructions, rupture, and hemorrhage. This is one of the pericardial cysts, just the X-ray and the CAT scan appearance of it. Moving on, most of the developmental cysts are identified on the CAT scan or the ultrasound. The diagnosis can be confirmed by an aspiration cytology, although most of the times they're not filled with blood, but sometimes when you're seeing a cystic image, and you can check the Hounsfield unit, or you can do an MRI to confirm that it's not blood, then you feel more comfortable doing an aspiration cytology in them. The pericardial and bronchogenic cysts can be followed with serial imaging and need not be dissected if asymptomatic. Therapeutic aspiration and thoracoscopic or mediastinoscopic excision for symptomatic patients is required. Moving on to the neurogenic tumors. They are posterior mediastinal tumors and they arise from neural tissues. as I was saying, 20% of adult cases and about twice that proportion in children. They appear radiographically as unilateral paravertebral masses. Most of the symptoms are chest pain. They're either from nerve or bone erosions. They can have dyspnea, which is secondary to tracheal compressions most of the times. And then neurological deficits resulting from spinal cord compression by the intraspinal tumor extension is seen. May be hormonally active, and you can sometimes see that as one of the symptoms as well. Moving on, MRI is indicated for suspicion of a neurogenic lesion. And then surgical resection is important to alleviate the local symptoms from mass effects of the tumor. Um, you can see neoplasms which could be arising from either the peripheral nerves, sympathetic ganglia, or paraganglionic tissue. So when they're arising from peripheral nerves, they're typically neurofibromas, schwannomas, and neurosarcomas. The tumors arising from sympathetic ganglia are ganglioneuromas, ganglioneuroblastoma, and neuroblastomas. And then the ones which are arising from paraganglionic tissues, the pheochromocytoma and then the paraganglioma. Different names, but just important pathologically and important in terms of treatment as well. Um, just trying to summarize it here. If you have a suspicion for a mediastinal mass, a CAT scan is generally a good test to begin with. If you see a solid or a cystic mass, if you don't see any solid or cystic mass and you see vascular abnormality, diaphragmatic hernia, extramedullary hematopoiesis, or other benign lesions, you can continue to watch them, or you can do different investigations in terms of what you see. But if you see a solid or a cystic mass, you can try and divide it into an anterior, middle, and posterior compartment. For the anterior compartments, if it's well encapsulated, it's typically a thymoma, a germ cell, thyroid goiter, carcinoma, or mesenchymal tumor. They are better to be just resected straight away, especially if it's symptomatic. But if it's not a well encapsulated mass and we don't know what exactly it is, then this is likely a lymphoma, unresectable, or a metastatic disease. So in those cases, diagnosing them is important in terms of a needle biopsy or a surgical biopsy. By needle biopsy, I mean bronchoscopically doing an EBUS mediastinal lymph node biopsies. We can do needle aspirations, we can do needle biopsies, we can do cryobiopsies in the mediastinum as well with bronchoscope these days. And if none of that is possible, surgical resection is always an option. When it's a middle compartment mass and you do see lymphadenopathy, then again, it could be a metastatic disease, granulomatous, or an infection. So three major classifications there. All three definitely need EBUS TBNA or EBUS biopsy or cryobiopsy. So when you do a needle aspiration, it can give you the diagnosis, but sometimes it becomes a little tricky to do next generation sampling for a tumor. So they need sometimes core tissue, and you can do EBUS forceps biopsies, you can do EBUS cryobiopsies as well. The cryobiopsies are helpful to preserve the texture of the tissue, and diagnosing them pathologically is important, especially when you're dealing with a lymphoma. Talking about cystic lesions in the middle, typically they are either bronchogenic cyst or pericardial cyst. And as I said again, the bronchogenic cyst, one way or the other, would start to cause some symptoms. So they're better that they're resected. But the pericardial cysts are the one which can be observed unless it's complicated. The posterior mediastinum masses typically are solid. And when you see a neurogenic tumor, when you diagnose them, it's probably surgical, which is the better option because it'll be diagnostic and therapeutic at the same time. So just a summary, just to summarize about the mediastinal masses. Now, the take-home points for the presentation would be the majority of the mediastinal masses are benign. That being said, because the number needed to harm is like less, we definitely need to keep an eye on the ones which are malignant. The likelihood of a mediastinal mass being malignant depends on the compartment where it is, patient factors, and the presence of the symptoms. So keeping an eye on those, if you think that there's a slight suspicion, then it should be worked up further. symptomatic masses are more likely to be malignant, and those will be the easy ones to categorize. If a patient has a mass which is big enough to cause symptoms, then this would definitely need further intervention. A chest scan with contrast should be obtained to evaluate any mediastinal mass detected by conventional radiography. And I say with contrast because that gives you more clarity in terms of the mediastinal imaging, be it a lymph node, be it a cyst, um, unless the patient has any contraindication for contrast, of course, where MRI becomes the option of choice. Going to the next slide, as I was telling you, the most common mediastinal masses, the anterior ones are thymoma, germ cell tumors, and lymphoma. If you can just remember these three. The middle ones will be lymphadenopathy and the developmental cysts. And the isolated mediastinal adenopathy, again, is more likely of either an infectious etiology or cancer or granulomatous etiology like sarcoidosis. And then the posterior compartment mostly are neurogenic tumors. So if we just remember this as well, this will deal with at least 80% of the pathologies of the mediastinal masses. Most mediastinal tumors and cysts should be surgically removed due to potential for malignancy and local compressive and invasive effects on the adjacent vital structures. Now, this is contrary to what I said in the beginning that most mediastinal masses are benign. When I say this, I mean a mass which is having some symptoms, which is having local compressive effects or invasive effects, or which you think could be malignant, it's better to resect it rather than wait for it to become malignant. These are my references. I took some articles as well from the Annals of Thoracic Surgery. So any questions, I will be happy to answer.
All right, does anyone have any questions?
Quick question. How far does it make sense to move people much beyond just a CAT scan? If you are working somebody up initially, before referring them to a specialist, or is it how far should a primary care person go?
Yeah, good question. I think if you see something in the mediastinum, it's on the regular CAT scan. I think it's just better to get an opinion as to which one could be better. Sometimes a CAT scan with an IV contrast is sufficient, but sometimes it needs to be worked up with an MRI. And sometimes, if we have very high suspicion for lymphoma, we would straight away take the patient for an EBUS. So I think just seeing a mediastinal mass on CAT scan is good enough for referral.
All right, you had a question? In the chat, and it said, are patients with routine masses like the lymphomas on their extremities and such more likely or prone to have more serious masses elsewhere, and should they be monitored for such?
Yes, good question. So patients with routine masses like lymphomas on their extremities and such more likely to prone or have more serious masses elsewhere, and should they be monitored? So again, it could be the presentation. Sometimes you can have lymphoma presenting elsewhere as well. You can have other tissues as well. It just depends which is more accessible. If somebody has a subcutaneous lymph node, let's say in the neck, like supraclavicular lymph nodes, or anterior scalene or posterior scalene lymph nodes, they are easy to get and they're easy to be excised. For a diagnosis of lymphoma, an excision biopsy is sometimes the best bet. And those lymph nodes are easy to like just excise all in all. But if they also have mediastinal lymph nodes and the subcutaneous nodules are at difficult spots where IR cannot reach or general surgery cannot reach, then we can also do something called cryobiopsies for the mediastinal masses, which again preserves the texture and is helpful in diagnosis. I don't know if it answers your question, but Just relating your question to mediastinal masses, they do have extra mediastinal infiltrations as well. They can have lymph nodes there, and they can be worked up as well, assuming that this is part of all the same disease.